Hello, welcome. My name is Michael Burlow. I'm a nurse practitioner and I'm the Vice President of Hospice and Administrator for Thema Hospice and Maggie's Palliative Care Hospice. Today we're going to talk about some diagnoses that focus more on neurological diseases and what helps qualify somebody for hospice. So before I begin, and I apologize for reading some of this stuff, but I think it's really important. I'm going to get up on my pulpit here and give this little preface that we as caregivers are given a responsibility to take care of those that are entrusted to us. Therefore, it's imperative that when we're interacting with them for the first time, we take into consideration the journey they've already been on. This is especially true when we're encountering patients with dementia and neurological diseases. Not only is it important for us to get a clear picture of the patient's current situation, but it's equally important to understand how the patient's condition has affected the family throughout the onset of the diagnosis and subsequent decline. This will be instrumental in our ability to help treat the patient and help the family understand and cope with future changes. So, I mean, if you think about that, just to translate that into terms, when we're talking about Alzheimer's patients, the thought process is that folks that go through Alzheimer's and their families, they mourn twice. They mourn once a person is diagnosed and watching their loved one disappear in front of them, from the person that they were to the person that they become. It's a journey that they're going through. And then they mourn again when the patient actually dies. So what happens is when we get a referral, we get a piece of paper. It's a snapshot. Right? Somebody made a diagnosis somewhere and somebody did an assessment somewhere, and it's just a snapshot in time. And so then one of you wonderful TCSs go out and you meet the family. It's really important to understand that this family has already been dealing with this for months or years, and they've gone through this journey so that we can help understand where they are to help get them to the finish line. So, with that being said, let's talk about the overall theme, which is dementia. And dementia is a group of neurological conditions that cause a decline in mental ability and interfere with daily life. It's characterized by the loss of the ability to think, to remember, and to reason, and can affect a person's judgment, language, and behavior. Dementia is more common as people age, but it's not a normal part of aging. In fact, there are many people that live into their 90s and beyond without any signs of dementia. And I can't tell you how impressed I am when we run across one of these 102-year-olds that are just sharp as a tack. I wish I could be one of those people. Dementia is not a disease. I'm going to emphasize that again. It's a set of symptoms often caused by a disease like Alzheimer's or Parkinson's or stroke. It's the sixth leading cause of death amongst the geriatric population. So again, let me reemphasize that. It's not a disease. And so you all are going to see this a lot. You're going to, and you have to kind of negotiate this because we get a lot of referrals from physicians that say, oh, admit to hospice for dementia. Okay, so here's the parallel. Jamie has emotions today. Well, that's great. You just told me what's going on with Jamie, but what kind of emotions? And what caused those emotions? It's the same thing with dementia. People have dementia, but what caused the dementia, right? And what kind of dementia is it? So dementia itself is the result of something else. And that's what we have to keep in mind, because the doctors in the community don't understand that for our particular professions. Yeah. Okay. So here we go. These are the types of dementia. And what I'm going to do is I'm just going to kind of briefly go through the first 8 and give you a little tidbit. You can also refer back to this PowerPoint at any given time, but really the last 3 are the ones that we really want to focus on. Okay. So reversible dementia. Let's talk about that first. Let me jump down my slide here. So reversible dementia means that it's something that's, again, it's not a disease. It's a process. So it has emotions, right? Okay, so it's an overarching thing. So again, last night You know, I could have gone out and boy, they kept telling me not to have those shots of tequila with my vodka but I didn't really listen. And this morning, well, I can't remember what the hell happened last night, right? Well, I had dementia, but it's reversible. And after the hangover wears away, I should be back to where I was, right? So reversible dementia can happen for various reasons, okay? Think about, we put somebody on morphine and really gork them because they've never had narcotics before, they are going to be demented. But if they stop the morphine, it comes back, right? It's reversible. It's a temporary situation that caused a thought process change, but it can be changed back.
Feel like it's encephalopathy.
No, we're gonna get to that. That's on here. So vascular dementia is kind of the opposite. And so if you think of it in terms like this, the body has all these pipes, right? We got our veins and our arteries, and the way it works is coming out of the heart, you got the big pipes, and the pipes go down throughout the body until they get smaller and smaller and smaller and smaller until they end at your various extremities of the fingertips, the brain, the feet. Those are the tiniest pipes, the capillaries, right? So when people have certain diseases like diabetes and other various vascular diseases, those small pipes are the ones that get affected first and are destroyed. And so now think in terms of the brain, because all those small pipes wind up in the brain. And so if you have somebody, I'll just use diabetes as an example, when they have really serious uncontrolled diabetes, those small vessels are the first ones to die. So they get numbness in their fingers, they get numbness in their toes, they get these paresthesias, but it also affects their brain. The small capillaries die. And so that blood flow that helps the brain process dies. It causes dementia. Okay. Frontotemporal dementia. This is a pretty horrible disease. We see this a lot of times with younger people in a variation called Pick's disease. This is when the frontal part of the brain is affected by dementia, and the frontal part, the temporal and the frontal part of the brain control our operations, the things that we do, our walking, our talking, our interacting, our functional abilities. And so sometimes these disease processes specifically attack that area of the brain. And when that happens, you see this dramatic decline. Unfortunately, people like Pick's disease affects young people. And I mean, it can affect people in their 30s. And it can be a very rapid decline from being, a normal functional individual to basically wandering and have behavior issues and all kinds of stuff and rapid decline to death. Creutzfeldt-Jakob, I'm sure I mispronounced that. Mad cow disease. So it was a real big thing in the 80s when it was first kind of uncovered. And so what we're going to talk about here is 3 different types of a very similar process, and it's prions, tangles, and Lewy bodies. And those are all things that form in the brain that cause functional decline. Okay, and so with mad cow disease or Creutzfeldt-Jakob's disease, initially cows got it. It's called, forgive me, but it's bovine encephalopathy, something or other. It's a cow disease, and the cows were getting it, and people were eating tainted meat, and it transferred to people, and this is irreversible. When you get it, you die. There's no cure for this. Now, in America, we rarely see this. Our crops are fairly well controlled, but having said that, we've had 2 cases of this in northern Arizona for some strange reason. So it happens. And what this is the prion. And what the prion is just a protein that is misshaped. And so if you think again, proteins make up our body. They're just a series of amino acids that make up your tissues, your organs, all that kind of stuff, your muscles. In the brain, you have these proteins that are misshapen, and there's no way to fix it. And that's what mad cow disease is. Korsakoff syndrome. Korsakoff syndrome, and we don't see this very often, but what this is it's a B vitamin deficiency. It's thiamine. And what happens is it's from alcoholics. And what happens to them is that they drink so much alcohol, it destroys their liver, and the liver is where you absorb B vitamins. And without B vitamins in the brain, your brain has dementia. It requires those B vitamins to process and stuff. So it can affect people that have B vitamin deficiencies, but mostly we see this with alcoholics.
And then
It can. And so this is why you also see those people that go on benders and wind up in the hospital and they get these yellow bags of B vitamin because the liver has now been toasted to the point where it's not absorbing B vitamins. And so they got to put it into your veins to try to get it to your brain. Okay.
that's a lot of patients are
Yep.
totally.
Mixed dementia is exactly what it sounds like. It's just somebody who has a series of different types of dementia. Okay. Hydrocephalus, getting back to Anne's question. And I'm just going to talk about this in simplistic terms. This is just water on the brain. And a lot of times it's the cerebral spinal fluid that's caused an increase in water in the brain. And again, anytime the brain is affected, any way we talk about this, whether the capillaries die or somebody's in a car accident and there's a mid-level shift of the brain, or you have fluid on the brain that's pressing on the brain, it's going to cause functional problems, dementia, confusion, behavior issues, what have you. So basically, it's just compressing the brain from excess fluid.
Isn't concussion a big?
Can be, and that's exactly right. So you get a concussion, you get inflammation, sometimes you get a brain bleed, and a brain bleed will cause pressure on the brain, dementia. A lot of times it's reversible. Over time, the blood absorbs, the brain restores to its size, that kind of thing. And so it's more that the pressure is what's causing the dementia while it's happening. Huntington's disease, god-awful disease, and it's hereditary. And that's really the only way you can get it is through, there are tests you can take to see if you have familiar genes that will pass this on. But somebody who gets Huntington's disease, it is terminal. There's no cure for this, and you will see horrid changes in a person. It's almost like Alzheimer's. You lose the individual. They, over time, start to develop behaviors and sometimes violent behaviors. Yeah. And then that's the worst part about it. It's like nowadays we have tests to tell whether you have a family disposition to Alzheimer's or Huntington's. The question is, do you want to know? I mean, what if you're, 18 and you find out, oh, Jesus, I'm going to have Huntington. What do you do with that? So, yeah. Okay. So those are kind of the big 8. So here's what I want y'all to get, and you're going to hear this thrown around all the time because we use this with everything. In hospice, home health can use this. They use it for hospital all the time. This is the functional scale. This is the PPS, the Palliative Performance Scale. And all this is telling you how functional a person is. Hopefully, you and I are 100%, although I guess I put myself more in 90%. But if you look at the chart, you go out there and you've got an H&P in front of you, and you go out there and you look at somebody and you say, oh my gosh, where does this person fall on the palliative performance scale? Well, I guess I'd look, are they able to do their activities of daily living? Are they dressing themselves? Are they shaving themselves? Are they getting dressed and putting their clothes on by themselves and that kind of stuff? Or are they bedbound? Or do they use a walker? What's their mobility? So basically, you just kind of run down the chart here and put them in a box. Where do they fit? And so this can be used with everything we do in hospice. However, when we get down to that 30% level, that's what we're talking about today with all of our neurological diseases. And the reason is Most of these diseases, like Alzheimer's and Parkinson's, they can go on for years and years and miserable, unfortunate years, right? But when they get to that 30%, scientifically, they've determined that's about 6 months or less. Okay, and so
What's
that's,
bad feeding to?
no, in most cases, when they are at 30%, that means they really that means it's appropriate for hospice. But this scale can be used for everything. I mean, if you think about it, person who has cancer metastasized throughout their body, they're gonna, maybe the doctor's given them 4 weeks, but they might be a 50 or a 60. They might be walking around, talking, dressing, because it hasn't affected their brain or their function as far as most of their daily operations, but they've declined. But you could say, this is a cancer patient, PPS is 50. So the point is this scale applies to everybody, right? And you can put any patient onto this scale, but for the sake of the neurological diseases that we're talking about today, 30 is your baseline. Okay?
Can you talk about the difference between being bedbound and somebody who it takes a max assist or a Hoyer lift to get it?
So bedbound means bedbound. It means that they can't get out of bed on their own. On their own accord. Right?
Can't roll over to be changed.
Well, and so that's interesting, and we'll get to that with the FAST scale, because the FAST scale actually breaks it down even further than that. Okay. All right.
Yeah, but you could use the PPS for,
PPS can
that
be used
patient.
for everybody. Jamie's 100 right now. I'm a 90.
110.
Wow, you took 10 of mine.
Yeah.
All right. So Lewy body dementia. This is a really, really interesting diagnosis. And I'm going to say that the next 3 diagnoses, the Lewy body, the Alzheimer's, and the Parkinson's, really are disease processes that can't be verified until somebody dies. If we did an autopsy, we would go in their brain and we'd say, oh, look, there's the presence of Lewy bodies. There's the presence of prions. There's the presence of tangles for Alzheimer's, right? So the true verification could only be done through an autopsy. However, there are things that you could see that are pretty prevalent that doctors are comfortable saying, oh yeah, this is A, B, or C. Okay, so for Lewy bodies, this is a specific one where there's a deficit because we've got what they call Lewy bodies, which again is a presence of a protein that has been misfolded, and they can find that in the brain on an autopsy. But the ramifications are that a person starts to decline, and you'll see it in their functional ability, the visual hallucinations, acting out in their dreams. So they're having a fight in their dreams, and they're physically throwing punches and stuff like that. So they don't have that paralysis that most of us have when we sleep. They are physically active during their dreams. And they can have these Parkinsonian signs, which we'll talk about in a second, which is that muscle rigidity and the tremors and that kind of stuff. The biggest telltale sign that pinpoints somebody for Lewy body is visual hallucinations. And I'll give you the case in point. When I was a nursing student, I did one of my clinicals in Margaret T. Morris, which is an Alzheimer's facility, and I was working with a patient with Lewy bodies, and we were literally sitting outside in the backyard of the garden on a bench having this conversation. Normally, I'd say this guy's probably a PPS of 60 or 70, so you know right now that he's fairly functional. We're having a pretty lucid, rational discussion. And the next thing I know, this guy is on the ground. He's in Vietnam. The planes are dropping bombs, and he is screaming at me to get down. And it's real to him. He sees it. It's visual hallucinations. Okay. And so I don't know, I guess the proper protocol in a situation like that is please make sure the patient is safe. Make sure you're safe. And just let it go. There's not much you're going to be able to do to bring somebody out of that state. It just kind of has to process. And it did on its own. After about 2 minutes, he kind of came around like a seizure and we were back on the bench talking again. So it's just a manifestation of his brain misfunctioning, not having the communication process that it should. But those visible hallucinations are the telltale sign of Lewy body. Okay? Parkinson's. So Parkinson's is a very progressive disease. Over time, it's been around for a long time. They used to call it the shaky palsy. There are a lot of very definitive signs that you can pretty accurately to say this person's got Parkinson's. The main one is bradykinesia. And bradykinesia is a slowness of movement, and more so the inability to start movement. So like they can't get themselves going. And once they get going, they can continue, but they can't initiate the movement. Also, the muscle rigidity. Like, I don't know if you saw many years ago, De Niro, I think it was De Niro that did the movie Awakenings. I think it was De Niro. I can't remember who the starred in it, but that muscle freezing where before they came out with drugs for it, people literally got to the point where they froze because the muscles got so rigid and they just didn't understand it at the time. This is a lack of dopamine in the brain. And without getting too technical about it, you got all these transmitters in the brain that give signals for your brain to work back and forth, and it's functioning with dopamine. Okay, and so these folks have a lack of dopamine. We have drugs that we give people, carbidopa, levodopa, and it helps when they're first diagnosed. It helps reduce those symptoms. I'm starting to feel a little bit rigid. I take my carbidopa, levodopa, I can relax. Or then they start to set in with those tremors, right? And the carbidopa will help them. But unfortunately, this is very progressive. And as it gets worse and worse and worse, we keep increasing the dose of the carbidopa, levodopa. There's a whole bunch of new drugs, variations of this that are somewhat helpful and keep helping people restore back. Eventually they get to the point where they might want to get one of these deep brain stimulators put in, and that helps give them relief for a certain amount of time. But at some point, there's no coming back. It gets to that point where we don't have a way to fix this anymore, and they progress. And so really the thing for us to look at, again, PPS of 30, but more so with Parkinson's, and this just is kind of the baseline that I go by. They get really rigid and they have trouble walking and they start falling a lot. That's really kind of the beginning of the end. But even more so, most people with Parkinson's have some pretty common features. They have digestive issues, constipation, diarrhea. The digestion is just not working anymore. And they have secretions, lots of secretions. And so they get to the point where they start to aspirate. And I'm going to tell you, and you can apply this across the board, any patient that we have with any diagnosis in the world, when they start aspirating, the beginning of the end is near. Because they are going to catch pneumonia, they're going to aspirate some food, they're going to catch pneumonia, and it's all over. So when we look at these Parkinson's patients, we're really looking for that end stage where they're falling a lot and they're having problems with their food. That means we're in that window.
I think that's where the conversation with those neurologists come from, right? That's where you're really painting that picture is when you're concerned about your Parkinson's patient, it's time to think of me when they start to have more falls, when they start to have aspiration issues. That's when you really need to start thinking about referring to hospice. That's how you.
Not necessarily, because they could be wheelchair bound for, like, they're not far along on, but they could be wheelchair bound. You kind of have to look at the big picture. It could be, but
Maybe
then
with aspiration,
are they aspirating
right?
too?
Are they
right?
aspirating?
Where are they in that process? And that's right. And this,
That's they
the reason I say falls is because we all know with any of our patients, one good fall can take them out. Right. I mean, so that's a sign that this is really advancing. But it could be like, I'm falling a lot, I'm just gonna sit in my wheelchair now for safety.
Yeah.
And then might go on another
Yeah.
2 years.
If the wheelchair is preventative, because they're gonna fall. If they're not in it, then they have an increased number of falls, right?
So here's a bigger issue. Most of these folks, and you're gonna find this to be true, for the last X amount of time, their neurologist has been their world. Right? They've been getting medication that really takes them from a state of just god awfulness. Tragedy and oh my God. And if you think about it, when you have tremors, it's work. It's work like anything else. And so you're literally exhausted when you relax. So their neurologist has been their God. Right? And asking somebody to come onto hospice means giving up your neurologist. And that for them is a monumental shift, right? Oh no, I gotta go. He's been there for me. So it's a hard thing. So just keep that in the back of your brains while you're talking to these people about this is what it means to come on to hospice. And we can help keep them comfortable, but we're really going to catch them in those end phases where there's nothing else the neurologist can do.
Well, it's not too hard to get in to see your neurologist.
Yeah.
What does the neurologist? Well, they prescribe tonight, probably, but no. Okay, well, now I can't get in.
We can do that.
No, you're on FEMA. So we are not gonna take you all those medicines.
That's
Make you comfortable and go for the life.
perfect.
You're gonna monitor that, if you're gonna do whatever. And yes, if you get a UTI, we're gonna treat it.
So you're absolutely right. And so for the people that couldn't hear Ann out there, you know, there is a point where they can't get in to see the neurologist, but our doctors will continue the medication. It's not that they're going to lose the medication or the deep brain stimulator or any of that stuff. We don't take that stuff away. Now, the caveat to that is, again, there are some of these newer medications that we've run across, and I apologize, I can't think of the one we've seen a couple of times recently, but way freaking expensive, and we won't cover that. And so that's a decision that the family has to make, whether they're going to continue with a neurologist or not. But in many cases, we can write the scripts for the carbidopa, levodopa, and kind of keep them comfortable with the understanding they've reached their max dose. There's nowhere for them to go. And so now we're going to help them keep comfortable. Okay.
Another thing that I always think of is their voice quality.
Absolutely. You'll hear it not only in the voice quality, but
This and
the
this.
tremors in the voice. It's vocal tremors. Right. Good point. Okay, so then moving on to the big one, Alzheimer's. Neurodegenerative disease usually starts slowly, gets worse. It's 60% to 70% of the cases that we see. And honestly, a lot of people get this for years prior to them even knowing they have it, or they don't recognize it. And we all think it's part of aging or whatever. And, you know, I worry about it all the time when I can't remember somebody's name because I've always been bad with names. But now that I'm older, I worry about Alzheimer's, blah, blah, blah. So damage to the brain, again, can appear years before the symptoms show. This is abnormal proteins and plaques and tangles is how it's referred to. And that's what they would find on an autopsy. But obviously we won't know that. But we do diagnose this by the symptoms. And essentially what's happening again with Alzheimer's is those plaques and tangles are literally disrupting the transmission of signals in the brain. And so you have a signal that helps you remember this, or you have a signal that helps you walk. And as these signals get disrupted, you decline. And right now, we don't have a way to reverse this. We keep seeing all these news articles about these new drugs that are slowing it down, or they're testing it in mice and they're seeing some changes. But right now, we just don't have very many good options for this. It is progressive, it is fatal. So this is the scary part. 5.2 million people 65 and older have this. 200,000 are early onset. Early onset is brutal, and we're talking people in their 30s and 40s that get this. By the year 2050, they say there's going to be 13.5 million to 16 million people with Alzheimer's, which is just incredible. And I don't know if that's because we're diagnosing it more or there's something in our environment causing it. We just don't know. So how do we know? How do we know when the patient's ready? Again, we're looking at that 30%, but the FAST score. And I love this. And you'll see this used inappropriately a lot of times. I know a lot of our nurses, oh, this is a congestive heart patient. Their FAST score is 6E. Well, you can do that. I mean, it's just a functional scale, right? But this one is specific for Alzheimer's. And it's appropriate to use specifically for Alzheimer's. And so this is, again, is the same as that chart. It's just you take your patient and you put them on this scale somewhere. Okay, so hopefully you and I are number one. Although I, in any case, I'm a number two. Just a joke. Not really number two. But as you work down, you know, we see more getting down to 6. And when it gets to 6, it divides up into specifics. Okay, and these are functional objectives. Can they put their clothes on? Can they, you know, do their daily activities? Can they bathe themselves? Can they flush a toilet, blah, 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 and then gets down to that D, urinary incontinence, and then E, the fecal incontinence. And the thing about the FAST scale that makes it different than the PPS scale is this is very, very linear. If you have an Alzheimer's patient, you can almost expect them to go right through each individual step. It's just the way that this disease process works. So when we get down to that 6E, and even more so, what Medicare says is appropriate for hospice is 7. We get into that 7, and then we're talking about their inability to have 6 intelligible words. And that's a really hard thing to quantify because a lot of people, there are people out there that have word salad. They might say 100 words, but none of it makes sense. So 6 intelligible, like can put one sentence together in the course of a day. Or might be giving yes and no answers and that kind of stuff, but more frequently. But when it gets down to not being able to do that, that's the patient we're looking for. Okay, and it really, excuse me, it really progresses from there. It's that inability to talk, the inability to walk, becomes bedbound, loses the ability to smile. And as Anne was alluding to earlier, the 6, what is it, the 6F? That's really, really pertinent. This is somebody who's lying in bed and can't sit themselves up on their own accord. I mean, that means the end is near. Okay, so the fast
So
scale.
that is H&P. And that might hold structure. She can't feed herself. She cannot do anything. Okay, but she's on a feeding tube, and so it's like, so why the feeding tube? Why the feeding tube?
So, well, there's a whole host of things there. And again, I want to just take a weird example. I don't know if this is the case, but I'm 16 years old and I'm in a car accident. And now I'm in bed and I can't lift myself up. That doesn't apply. That doesn't mean that person can go on from young and healthy.
And then scar tissue and everything else, and it built up and all this stuff. And what did she do? Anyway, they went in and tried to fix it and nicked it, and that's she's got that. She's cognitively enough with it, but his have fallen and all that kind of stuff in August. Now in and out of the hospital and everything else. And
so here's the issue. Right. So here's the issue is, as you indicated, the cognitive ability is what saves her. So really the feeding tube thing for us, and I'm just going to separate that from an Alzheimer's patient who's down to the point where maybe the family's chosen a feeding tube. When we get to that point, we see a lot of struggle with the family because they don't want to stop feeding their loved one. But for us, if someone's bedbound and they're getting a feeding tube and they're not with it, they're gonna aspirate. But being with it gives people the ability to understand what's going on and
Yes.
making sure that like, oh, I'm aspirating, stop the feeding or whatever. They could go on for a long, long time. But when you get to that point where the family's in control and the patient's not really responding and can't give input, they're gonna aspirate eventually and they're gonna die. Backwards aspiration, not down, but up, right? And so that's really, and if that were the case, if they had Alzheimer's and they
Yeah.
weren't, that's what the separation there, okay? So that's it in a nutshell. I hope that, and I want you to all get copies of this and I hope you can refer back to it, but I kind of wanted to separate out the three main ones we see and all these other neurological diseases, which you will run across. I mean, all this stuff is, except for the mad cow, is pretty common, but be able to understand and be able to have an intelligent conversation with a physician that says, oh, Ann, bring this patient on for dementia. Don't say no. That's your point to look at the H&P and figure out why does Jamie have emotions? Did I kick him? Or is he just happy to see me? Right? What's causing the dementia? The dementia. And so that becomes your task to help get this patient on. Because, the physicians in the community are trained to get people better. They're not trained for end of life. And so they're just going to give us this lump category. That's where we become detectives and sleuth this up.